good morning, good afternoon to all the clinicians, hematologists, and especially the students joining not only from India but across the world to the live webinar by Mumbai Hemato-Oncology Group and supported by Intas Oncology. Today's topic is how to diagnose lymphomas presenting as splenomegaly by peripheral blood and bone marrow studies. This series, which has started after COVID, during the COVID times, is a non-stop largest running series of education uh, in hematology space with the vision of Professor Dr. M.B. Agarwal, and lots of hard work has gone behind bringing stalwarts across the globe every weekend on the virtual platform. Thank you so much, sir, for initiating and continuing every weekend. And would request, sir, to take the proceeding forward.
Thank you, Ashish. Well, good evening to everybody from India, and good morning, good afternoon to those who are listening from other parts of the world. Today, our guest speaker is Professor K. Naresh from Fred Hutch, Seattle. He will be lecturing on how to diagnose lymphomas presenting as splenomegaly by peripheral blood and bone marrow studies. I would say very, very intelligent subject, something which is day-to-day problem, and let's see what the solutions are. This webinar is brought to you by Mumbai Hematology Group, supported by Intas, and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from Intas, Mr. Yash Kalpesh and team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Professor K. Naresh from Fred Hutch, Seattle. All our discussants who are themselves eminent hematopathologists or clinical hematologists or even hemato-oncologists and medical oncologists. And you participants for sparing your Saturday evening, morning, afternoon. Tomorrow morning, we have a discussion on management of newly diagnosed DLBCL from none other than Dr. Zurzek from Poland. He has been our speaker a couple of times in past, and tomorrow he'll cover how we sort of treat a newly diagnosed DLBCL in the year 2024. And this will be at 11:30 a.m. IST, Polish time 8 a.m. Our discussants, there are a fantastic number today who want to be here and discuss directly with Dr. Naresh. I'll very briefly introduce them. We have Dr. Purohit from Jodhpur, Dr. Mandloi from Mumbai, Dr. Amrit Kaur Keller from Mumbai, Dr. Anju Bharti from Varanasi, Dr. Ankur Ahuja from Pune, Dr. Arihant Jain from Chandigarh, Dr. Chitra Madiwale from Mumbai, Dr. Debdrita Ray from Bengaluru, Dr. Deepak MB, Bengaluru, Dr. Gopinathan, Chennai, Dr. Nin Mia Thanda from Myanmar, Dr. Sadri from Navsari, Dr. Jyoti Sane from Ahmedabad, Dr. Kunal Chattani from Nagpur, Dr. Kunal Goyal from Mumbai, Dr. Manu from Sri Lanka, Dr. Suri from Jammu, Dr. Angi from Ahmedabad, Dr. Taha Ali Khan from Hyderabad, Dr. Mayat Marlan Shah from Myanmar. Also Dr. Pujita from Hyderabad, Dr. Prerna Chautmal from Mumbai, Dr. Prerna Chaudhary from Jaipur, Dr. Pushpanjali Oza from Ranchi, Dr. Bala Subramaniam from Madurai, fellow Dr. Venkateshan from AFMC Pune, Dr. Satish Kumar from Bengaluru, Dr. Savitri Singh from Noida, Dr. Shivani Joshi from Nasik, Dr. Agale from Mumbai, Dr. Udyan Kachi from Gujarat, Dr. Vidisha Mahajan from Mumbai, and Dr. Y. Mon Thant from Myanmar. A long list who will be physically present to discuss with Professor Naresh, and of course we will have audience from all over the world who will put in their question in the chat box. Professor K. Naresh requires no introduction. All those who are in the field of hematopathology from India have witnessed his work in India when he was at TMH for a long evening before he went to UK and then US. And through these webinars, he has been educating all of us during last 4 years, almost twice in a year. So this may be 6th, 7th, or 8th evening when he has accepted the invitation. Extremely grateful to you because this is very early morning in that part of the world. He is a hematopathologist with focus on lymphomas, bone marrow pathology, and molecular pathology. He's in this field of hematopathology for over 35 years. He has worked, trained across 3 continents, that is North America, Europe, and Asia. Prior to joining Fred Hutchinson, he was at Hammersmith. He leads diagnostics, translational research, and training in hematopathology. He was the chair of the British Lymphoma Pathology Group. As a part of his activities of that group and Royal College of Pathologists, he played a critical role in improving standards of training and practice of hematopathology in the UK. He has over 300 publications, majority of which are in the field of hematopathology. In hematopathology research, his collaborations extend with investigators and institutions in US, Europe, Asia, and Africa. He's a firm believer in global medicine and science and in fostering international collaboration to promote translational research and training in hematopathology in other branches of medicine. I can go on and on, but let's come to the subject, and he will be speaking to us on how to diagnose lymphomas that present as splenomegaly by peripheral blood and bone marrow studies. I must say that here we either do a splenic biopsy or even splenectomy to diagnose these cases with accuracy. So this lecture is going to be a practice-changing lecture, and I'm sincerely looking forward to it. Well, thank you very much, and I will stop sharing. And hand over the platform to Dr. Naresh.
Thanks, Dr. Agarwal. I'm not sure whether I deserve all the things that you said, but I'll try to do my best for this lecture. Let me share my slides and hope you're able to see my slides and you can hear me well.
Yes, yes.
Yeah, in the next hour, or a little over an hour, I'll try to cover my approach, how I diagnose splenic lymphomas, and let's see. Okay, one of the problems of splenic lymphomas is that, we are not looking at spleen, and most often we are trying to diagnose a splenic lymphoma from peripheral blood and bone marrow, and that poses a lot of problem. I'll make a few general remarks on this. Then I'll go into the meat of the subject of diagnosing B-cell, initially B-cell lymphomas, and then I will go over to the T-cell lymphomas. But in the meanwhile, I will also try to introduce the changes that we brought in the 5th edition of the WHO classification, and what led to these changes, and how do we practice in light of these changes in the current classification. So how do we define splenic lymphomas? Usually when somebody says a splenic lymphoma, what we try to mean is a primary splenic lymphoma. The site of involvement is usually restricted to spleen, to bone marrow and peripheral blood, but can also involve splenic hilar lymph nodes. And I think by and large, one would use this definition to call something as a splenic lymphoma, and patient may have some minimal lymph nodal disease, but that's not the major site of involvement. Rarely you have specific other extranodal sites of involvement. We will come to it as we go along. But we have to also remember that there are quite a few other lymphomas which can have a splenic presentation. The initial manifestation may be in terms of a big spleen, but patient also, if you carefully look, has other sites of involvement. So very broadly, you can divide as those which are primary splenic lymphomas and where you have primary splenic presentation of a systemic lymphoma. And in both of these, you have B-cell and T-cell lymphomas. In primary splenic lymphomas, according to the current 5th edition of the WHO classification, you have hairy cell leukemia, splenic marginal zone lymphoma, splenic diffuse red pulp small B-cell lymphoma, which is no longer a provisional entity. It is a accepted entity. And then the new WHO classification introduces a term, splenic B-cell lymphoma leukemia with prominent nucleoli. This incorporates what used to be CD5 negative prolymphocytic leukemia and hairy cell leukemia variant. We will discuss this entity in more detail. Then on the T-cell lymphomas, we have T prolymphocytic leukemia, T large granular lymphocytic leukemia, and hepatosplenic T-cell lymphoma, where the primary seat of the disease is in the spleen. But as you can see here, there are many other systemic lymphomas which sometimes present with prominent splenomegaly with less obvious disease elsewhere, like CLL, SLL, follicular lymphoma, mantle cell lymphoma, lymphoplasmacytic lymphoma, T-cell histiocyte-rich large B-cell lymphoma, sometimes lymphoblastic leukemia and lymphoma, and diffuse large B-cell lymphoma. We will discuss the issues associated with this. On the T-cell side, like a systemic chronic active EBV disease can present with splenomegaly. Part of it could be because of hemophagocytic lymphohistiocytosis. And then you also have, we will discuss the possibility of peripheral T-cell lymphoma NOS with a primary splenic presentation. Let's start the discussion with a few slides. I think this is the pattern I'm going to follow for this lecture. Bring in a few slides, a few actual cases, then discuss issues associated with that and how we diagnose a particular entity. Here is a patient, a 50-year-old man who presented with lethargy, and splenomegaly 6 centimeters below the costal margin, had a high white cell count with prominent lymphocytosis and monocytopenia. And what you see in peripheral blood is cells with fairly dense chromatin, very smooth appearing chromatin with abundant pale staining cytoplasm. Some projections, but what is more prominent is the abundance of the pale staining cytoplasm, which is all around the nucleus. And some other areas, you again see something sort of similar, but in a rare case cell, you may see some projections, cytoplasmic projections. Here's more of the same. Here is one cell with some hairy projections, but most of them, the prominent feature is the dense chromatin, some nuclear indentation. Nucleolus is not prominent, and this abundant, almost like a pouched egg morphology. Other areas, if you look carefully, you may see some cells with hairy projections, but that was not a prominent feature in this particular case. This patient did not have any bone marrow, and what we had was flow cytometry, and in flow cytometry, apart from many B-cell antigens, what we also saw was expression of CD25, CD11C, CD103, CD123. So based on peripheral blood morphology and the immunophenotype, diagnosis is hairy cell leukemia. Here's another one where we didn't, the peripheral blood film was quite cytopenic. You can see the lymphocytes were only 0.5, monocytes were also 0.5. and there was also thrombocytopenia, and hemoglobin was fine. And the patient had symptoms related to thrombocytopenia, like easy bruising, and had a slightly enlarged spleen, 3 centimeter below the costal margin. And you can see fairly cellular bone marrow. And when you look at a higher magnification, you can see sheets of cells where the nuclei are located away from each other. So there is abundant cytoplasm surrounding these nuclei. Again, this is the classic morphology of hedical leukemia, where you have abundant, clear or pale staining cytoplasm surrounding the nucleus, and a cytoplasmic membrane borders are extremely distinct. There are interlocking cytoplasmic borders. And this morphology is very characteristic. Some of them have some nuclear indentations, but the cytoplasm and the interlocking cytoplasmic borders are very characteristic of hedical leukemia. And here it's CD20 positive. It's also positive for CD25, DBF44, and TRAP, which is one could also use CD123 and 103 on sections. CD123 works very well. One could use cyclin D1, and there is an antibody for mutant BRAF, which can also be used for specific diagnosis of hedical leukemia. And here is CD68R, which is a monocyte marker that is frequently expressed in leukemic cells of hedical leukemia. So this is what we found in this case. There was positivity apart from B-cell antigens to DBF44, CD25, CD123, TRAP, CD68 we assured you, and there was weak positivity for cyclin D1, and BRAF antibody showed positive cells. And mutation studies were undertaken, which was positive for BRAF mutation, and this is a classic bone marrow involvement by hedical leukemia. So hedical leukemia often present with pancytopenia, including monocytopenia. There are often low-level circulating leukemic cells, so sometimes it can be missed on a peripheral blood film. Patient usually has splenomegaly, and generally patients are asymptomatic. So the classic morphology is a small to medium-sized cell with oval, indented, kidney-shaped nuclei and bland, sort of ground glass chromatin. They have variable amounts of pale blue cytoplasm, which is with circumferentially located, prominent, and sometimes fine villus projections. But this is not always the feature. But what I have seen constant feature is the abundance of pale blue cytoplasm. A bone marrow biopsy shows patchy interstitial pattern of lymphoid infiltration, the fried egg cytomorphology, which I showed you in a couple of cases, due to abundance of cytoplasm, widely spaced nuclei, and prominent cell-to-cell borders. These are typical features of hedical leukemia. Some cases you may see extravasated red cells, something similar to what one would see in spleen, forming pseudo red cell lakes. And sometimes the marrow can be hypocellular. And when you think of a plastic anemia, make sure that you exclude hedical leukemia. And reticular fibrosis is often quite significant, so the bone marrow aspirate may not be cellular, and you may not be able to see these cells in bone marrow aspirate. The unifying feature for hedical leukemia is BRAF mutation, V600E, which is present in more than 95% cases. Often they have heterozygous deletion of 7q with loss of wild-type BRAF allele at 7q34, resulting in a sort of homozygous mutation. Mutations can also be seen in KLF2, CDKN1B, and KM22C. And as I discussed, I think the immunophenotype is quite characteristic of this disease. So this is a disease which can be diagnosed with a high degree of certainty based on immunophenotype and mutation studies. So the diagnostic criteria per the 5th edition WHO classification is expression of annexin 1 in addition to CD20, which is very useful on immunohistochemistry, or co-expression of CD11C, CD103, and CD25 on B cells by flow cytometry or immunohistochemistry. Desirable criteria is presence of clonal BRAF mutation and positivity to CD123, a bright CD22, a bright CD200, strong immunoglobulin expression, weak cyclin D1 expression, and TBX21 expression, either by flow or by immunohistochemistry. Here is another case from University of Washington, where you can see the typical features of hairy cell leukemia with expression of CD103, CD25, CD11C very strong, CD22 again extremely strong, CD22, and CD123, the characteristic features of hairy cell leukemia. We move on to another case here, which is different. Here's a 57-year-old man with anemia, thrombocytopenia, and massive splenomegaly and no lymphadenopathy. On a bone marrow biopsy, you can see there is a lymphoid infiltrate, which is vaguely nodular in this field. And morphologic features, in contrast to the previous cases which I showed you, here the nuclear density is higher, nuclei closer to each other, thereby suggesting that the cytoplasm is much less compared to the previous cases that we discussed. And the nuclei, again, have dense chromatin with some nuclear indentation. Here's another field. Some of the cells may start to show some plasmacytic differentiation, which is very subtle. Though the plasmacytic differentiation is subtle, there is significant expression of VS38C, which is a plasma cell marker. And these are plasma cells, and these are cells showing early plasmacytic differentiation, and this is CD20. And in CD20, if you carefully look, you can see areas where this linear arrangement indicating that the presence of these B cells within sinusoids. And again, here's another field where you can see a sinus which is filled with abnormal B cells. And this is a characteristic intrasinusoidal distribution of many of the splenic lymphomas. And in this case, we are talking about a splenic marginal zone lymphoma. So there is nothing very specific about the immunophenotype of a splenic marginal zone lymphoma. Often they express IgM and IgD, as in this case, and they're negative for many other markers like CD5, 23, CD10. Sometimes CD23 can be weakly positive. DBF44 can also be sometimes positive, and rarely you can express CD25 can be positive. But in this case, all these were negative, and this is a characteristic case of splenic lymphoma, which is compatible with splenic marginal zone lymphoma. I'll tell you why I say compatible with splenic marginal zone lymphoma in a while. Here's another splenic marginal zone lymphoma where you see nodular aggregates of lymphoid cells, and then interstitial and some intrasinusoidal infiltrates here. Here, the nodular aggregates are highlighted here, and here is CD20 highlights intrasinusoidal distribution. This is a different case. And this case showed expression of DBF44, and with CD23, within those nodules, you can see some follicular dendritic cell meshworks. Rare cases may even show you reactive germinal centers and expanded marginal zones. So splenic marginal zone lymphoma usually present incidentally with lymphocytosis or with splenomegaly, and often splenomegaly is quite massive. And about 30% of patients may have a small paraprotein, and about 20% patients have autoimmune manifestations. In peripheral blood, there's mild to moderate lymphocytosis, small to medium-sized cells with round nuclei or indented nuclei with condensed chromatin and smaller amounts of basophilic cytoplasm, and some of them may even have short villi. But these are often polar in distribution and not present all around the nucleus. Morphologic heterogeneity is often seen because there can be some lymphoplasmacytoid cells, and some cells may have relatively abundant pale cytoplasm. In bone marrow biopsy, as I showed you, you can have interstitial infiltrate, you can have sinusoidal infiltrate, or you can have a nodular infiltrate. In late phases, you can have diffuse involvement of the marrow. In some cases, you can see reactive germinal centers, and you may have expanded marginal zones. There is an association with hepatitis C for splenic marginal zone lymphoma, and often you see a skewed usage of certain IgH genes. And What is typically seen in around 30% and sometimes even more in some of the series is hemizygous deletion of 7q3132. And this is an important aspect for diagnosis of splenic marginal zone lymphoma. Similarly, is co-occurrence of trisomies of chromosome 3 and chromosome 18, and some cases may have CDK6 translocation. As I said, the immunophenotype is not very specific. Often they express both IgM and IgD. You can have MNDA expression. Again, MNDA is not specific. The only use of MNDA is to distinguish it from follicular lymphoma. And many times they may express CD5 or DBF44 or CD25. So, but they're consistently negative for CD103. So that's something which is very useful. So the essential criteria for diagnosis of splenic marginal zone lymphoma is identification that they are B cells, and if you have IgM and IgD co-expression, that is useful, and more important is to exclude a heritage leukemia, exclude a CLL, so exclude a mantle cell lymphoma. So exclude heritage leukemia with absence of annexin 1 or CD103, exclude mantle cell lymphoma with absence of cyclin D1 and SOX11, exclude a CLL by the absence of LEF1. And of course, patient should have a big spleen, and then you exclude other nodal lymphomas. Often the neoplastic cells are negative for CD5 and CD10. Here is another case of marginal zone lymphoma from the University of Washington, where you can see the phenotype is not anything that is specific. It can express CD200, and CD22 is positive, but not as strong as we saw in heritage leukemia. CD11C in this particular case is negative. There is weak expression of CD25, but it is negative for CD103 and CD123. The entity which in a peripheral blood or a bone marrow that very closely resembles splenic marginal zone lymphoma is splenic diffuse red pulse small B-cell lymphoma. If we have a splenectomy specimen distinction of splenic marginal zone lymphoma from splenic diffuse red pulse small B-cell lymphoma is very easy. In the splenic marginal zone lymphoma, you have involvement of both white and red pulp, whereas in splenic diffuse red pulp small B-cell lymphoma, it's primarily red pulp involvement. But when you look at peripheral blood and bone marrow, there is a huge amount of overlap. Usually these patients present with splenomegaly and lymphocytosis. There is often, again, a small paraprotein, which can be IgM, IgG, or sometimes both can be present. Similarly, lymphocytosis and lymphocyte morphology is not too different from that of splenic marginal zone lymphoma, and bone marrow features also are not too distinct from splenic marginal zone lymphoma. There are some differences in the molecular features, like CCND3 mutation, like mutations of the MAP2K1, which seem to be different in splenic diffuse red pulse small B-cell lymphoma as compared to splenic marginal zone lymphoma. One of the features which I haven't used in my practice is expression of CD180, which seems to be significantly associated with splenic diffuse red pulse small B-cell lymphoma. We will discuss one of the papers regarding this aspect. Again, the diagnosis is diffuse infiltration of spleen by monomorphic small B cells in the red pulp with atrophy of white pulp. So the diagnosis of splenic diffuse red pulp small B-cell lymphoma requires splenectomy. And peripheral blood features are not too different from that of splenic marginal zone lymphoma. And even in the bone marrow, as you can see here, you can see beautiful intrasinusoidal infiltrates. And again, it's important to exclude heritage leukemia by showing absence of BRAF mutation. This is a study which there have not been many studies regarding this. So I think there are more additional studies are required to validate these findings. So what the study suggests is that splenic diffuse red pulp B-cell lymphoma has stronger expression of CD180 as compared to splenic marginal zone lymphoma. and weaker expression of CD200 as compared to splenic marginal zone lymphoma. Though the marginal zone lymphoma itself is not, the CD200 expression is not as strong as in CLL. But if you look at the ratio of CD200 to CD180, it seems like having a ratio of less than 0.5 is a distinctive feature of splenic diffuse red bulb small B-cell lymphoma. And that appears to distinguish it from splenic marginal zone lymphoma. I do not have any personal experience regarding this, and it's worthwhile to reproduce these results. But the issue is not many patients will undergo splenectomy, so you don't have a confirmatory diagnosis. But it's still worth pursuing this. So I want to show you a case here, which is a useful demonstration. A 70-year-old man, the history, what was thought to be hairy-cell leukemia, diagnosed and treated for nearly 20 years. On flow cytometry, there was an abnormal B-cell population, and the B-cells expressed CD11C partially, expressed CD23 partially, CD25 partially, and there was lambda light chain restriction. And cytogenetics showed there was translocation 6-7, and 7, I want you to show the break point was on 7q32. Molecular analysis showed that there was no BRAF or MYD88 mutation. Morphologic features here, as you can see, these cells are medium to large in size. They have prominent nucleolus. Many of these cells have prominent nucleolus, and nuclei show indentation, and there's fairly abundant cytoplasm. And many of these have abundant flowing cytoplasm, and these have a prominent nucleolus. So there are some features of a splenic marginal zone lymphoma in terms of the cytoplasm. And also, again, I want to take you back to the 7q32 breakpoint, which is quite typical of a splenic marginal zone lymphoma. But what doesn't fit is these prominent nucleoli. The cells are larger than the regular splenic marginal zone lymphoma, and nucleoli are prominent. Here are more or the same, and some of them are really large cells with very atypical nuclei with irregular nuclear contours. But you also see in the background smaller lymphoid cells, which would go for a splenic marginal zone lymphoma. Something like this would go for a splenic marginal zone lymphoma. But you have plenty of cells with prominent nucleoli in addition to that. There was a diffuse involvement of the marrow by these abnormal cells. And you can see these are medium to slightly larger looking cells, but the morphology is best seen in peripheral blood. And like splenic marginal zone lymphoma, it is positive for IgM and IgD. It is also positive for TRAP and positive for CD20. So DBA44 was positive. Very rare, occasional cells were cyclin D1 positive, but we excluded mantle cell lymphoma also by cytogenetics and also absence of SOX11, CD5, and it was negative for CD123 and CD25. And I can't remember, CD103 should have been negative. Okay, just hold on. Yeah, so this one we said marrow involvement by splenic B-cell lymphoma leukemia, and now the morphologic features we will discuss in a while is typical of that of splenic B-cell leukemia lymphoma with prominent nucleoli. And I suspect this is a progression in a splenic marginal zone lymphoma. Here is another case, the 81-year-old man, much more recent case that I have seen, incidental lymphocytosis. Initially, he presented with a lymphocyte count of 29,000 with 77% lymphocytes and mild anemia. And his chest and abdomen pelvis CT showed that he had low volume generalized lymphadenopathy, but spleen was markedly enlarged and had multiple nodules. Some of these nodules were around 4 centimeters in size. And within a short while, the white cell count shot to 140,000 within a month, and a bone marrow biopsy was performed. Here's his peripheral blood. You can see, again, medium to large size cells with slightly irregular nuclear contours. And here's a bone marrow where you can see a heterogeneity in the cell size. You can see larger cells. You can see medium to large size cells, and some small cells. And here was the diffuse involvement of the bone marrow by similar cells. So by on flow cytometry, in addition to B-cell markers, there was CD11C in a subset of cells. There was a partial expression of CD38, and there was no expression of CD123, CD103, or CD25. There was an immunohistochemistry. B-cell markers were positive, but it was negative for a host of other markers. So on fish studies, there was trisomy 12, but no other abnormality was detected, no other translocations. P53 deletion was not there, ATM mutation was not there, but there was a host of other mutations. There were 2 mutations in ARID1A. There was mutations in Notch2, KLF2, and MYC. It's important to, again, if we go back to the splenic diffuse red pulse small B-cell lymphoma, one of the features was presence of Notch2 and KLF2 ARID1A mutation in splenic diffuse red pulse small B-cell lymphoma. Notch2 can be common between splenic marginal zone lymphoma and splenic diffuse red pulse small B-cell lymphoma, but more frequent Notch2 mutations and KLF2 mutations are seen in splenic marginal zone lymphoma, which are progressing. So what is the preferred diagnosis? Again, the preferred diagnosis here is a splenic B-cell lymphoma leukemia with prominent nucleoli, and the possibility that it is arising in as a progression of either a splenic marginal zone lymphoma or a splenic diffuse red pulse small B-cell lymphoma. It fits the definition of a splenic B-cell lymphoma leukemia with prominent nucleoli, with having a large spleen, a high white cell count, with large lymphoid cells showing prominent nucleolus. Why do I favor a progression from splenic marginal zone lymphoma, splenic diffuse red pulse B-cell lymphoma? Because the spleen is not only enlarged, but has got multiple nodules up to 4 centimeters in size, which would be unusual for a splenic marginal zone lymphoma. There is small volume lymphadenopathy outside of spleen and splenic hilar lymph nodes. So that's again probably indicative of progression. Then presence of a minor component of smaller lymphoid cells, which tells us a tale that there was probably an indolent B-cell lymphoma in the background. CD11C is a minor point, but importantly, mutations in ARID1A, KLF2, and Notch2, which relates this to splenic lymphomas like splenic marginal zone or splenic diffuse red pulse B-cell lymphoma, and a progression occurring in these lymphomas. Can it be a diffuse large B-cell lymphoma of spleen? I mean, it's difficult to exclude that, but in the overall context of patient having only small volume lymphadenopathy and having a big spleen and then spleen developing nodules, it's less likely diagnosis. Of course, the genomic changes that we have seen here can also be seen in a diffuse large B-cell lymphoma. So we said our preferred diagnosis was a splenic B-cell leukemia lymphoma with prominent nucleoli in this case. So here's another patient with massive spleen, no lymphadenopathy, anemia, very high white cell count, thrombocytopenia. This is from one of the old Hammersmith cases with the CD5 negative, IgM, IgD positive, kappa positive, and FMC7 positive. And this is the morphology here, where you can see cells with prominent nucleoli, some cells without nucleoli, but majority of the cells with overwhelming majority showing a single large prominent nucleolus. In the past literature, these would have been called as a prolymphocytic leukemia, B-cell prolymphocytic leukemia. Here you can see some smaller cells, but more than 55% cells in this case had these kind of larger cells with a prominent nucleolus with typical features of prolymphocytes. Again, here you got some smaller lymphocytes and typical prolymphocytes. And so here, what would have been called as CD5 negative B-cell prolymphocytic leukemia, in the current WHO classification, it would be classified as splenic B-cell leukemia lymphoma with prominent nucleoli. We will address why we changed the terminology in a while. Here's another patient, again from the old Hammersmith collection, a 77-year-old man who presented with gout and congestive heart failure, anemia, very high white cell count, spleen 35 centimeters, and mild thrombocytopenia, no lymphadenopathy. B-cell markers were positive, CD5 was negative, surface immunoglobulin with kappa light chain was positive, FMC7 positive but negative for CD5, 103 and 123. Here you can see cells which are medium to large, again, have got hairy projections toward one side. Again, hairy projections on one side, and many of these cells have a prominent nucleolus. They are fairly a moderate to fair amount of cytoplasm, and the hairy projections become very prominent, but most of them are not evenly distributed throughout the cytoplasmic borders, and most of these cells are much larger than a hairy cell leukemia, and most of them have a prominent nucleolus. Here, more from the same case, showing you a prominent nucleolus, abundant cytoplasm, and these cells are much larger than hairy cell leukemia. In the past literature, this would have been called hairy cell leukemia variant, and this would be reclassified as splenic B-cell leukemia lymphoma with prominent nucleoli in the 5th edition WHO classification. Here's a case from, again, from Hammersmith Hospital, which, where you can see bone marrow infiltrated by abnormal lymphoid cells, and you can see here it is present within a bone marrow sinusoid. These cells are larger, and you can see they have a nucleolus in many of them. And here is CD20 highlighting the intrasinusoidal and some interstitial pattern of infiltration of bone marrow by these abnormal B cells. And these cells express DBF44 and show weak expression of CD11C. Again, this would have been called a hairy cell leukemia variant in the past, and it would be reclassified as splenic B-cell leukemia lymphoma with prominent nucleoli in the current WHO classification. So what were the issues? Why did we change the name? Why did we discontinue the terms B-cell prolymphocytic leukemia and hairy cell leukemia variant? For BPLL, the distinction of BPLL from CLL with increased prolymphocytes was very difficult. And the cutoffs of 55% was artificial. One can imagine the biology of a disease with 50% prolymphocytes would not be any different from the biology of a disease with 60% prolymphocytes. So this artificial cutoff of 55% did not seem to have any biological relevance. There may be many diseases. If you look up the literature, you will see follicular lymphomas and lymphoplasmacytic lymphoma and many other lymphomas, including splenic marginal zone, splenic diffuse red blood B-cell lymphoma with more than 55% prolymphocytes. So disease other than CLL can have prolymphocytes and can cause confusion. BPLL did not have a defining genetic abnormality, and the morphologic, phenotypic, and genetic features were all highly variable, including patient outcomes. And as time went by, the disease became more and more rare, with very few cases being diagnosed. So it became untenable to have this disease as a unique disease. The same happened with hairy cell leukemia variant. And hairy cell leukemia variant has got nothing biologically similar to hairy cell leukemia. The genetics is different, the morphology is different, the immunophenotype is different, responses are different. So if it has nothing in relationship to hairy cell leukemia, calling that as a variant of hairy cell leukemia would be most inappropriate. So again, it did not have a defining genetic abnormality, and the morphologic, phenotypic, and genetic features and outcomes were highly variable. And again, this was a very rare disease. So all these aspects led to discontinuing these two terms. And here is just to take a historic perspective of B-cell prolymphocytic leukemia. Again, this was an entity which came into light at the Hammersmith Hospital, my old place. In the same year, there were in 1986, there were 4 papers from Junior Mello as the first author, which described this entity very meticulously. And when they looked at CLL and its relationship to BPLL, they came up with 3 subsets. One was with less than 10% prolymphocytes, which was typical CLL. Then you had more than 55% prolymphocytes, which was prolymphocytic leukemia. And those which were in between 11 and 55% was called CLL/PL. And what is important to remember here is 1/3 of patients with typical CLL over a period of time developed prolymphocytes more than 10%. So they moved from CLL to CLL/PL category. And 18% of patients who were initially diagnosed as CLL/PL eventually had more than 55% prolymphocytes, and they moved into prolymphocytic leukemia category. So again, bringing into question about the distinctiveness of these subsets. And if this is another, in the same year from Junior Mello, there was another paper at the part of the 4-part series where they looked at the cell size of different cells. And here's a beautiful photograph showing distinctive cellular populations in a CLL case, a CLL/PL case. You've got small lymphocytes, large lymphocytes, and then you have the prolymphocytes here, with typical features, a prominent nucleolus, abundant cytoplasm, and then large lymphocytes or immunoblasts. But if you look at here, they showed the sizes, the median size of different cases are plotted here between CLL, CLL/PL, and prolymphocytic leukemia. Though there is an increasing median size of the lymphoid cells from CLL to PLL, you can see there is a huge overlap between different cases. So again, bringing into question whether these are really distinct diseases. In the more recent literature, if you look at the prolymphocytic leukemia genetics, you don't see anything that is unique. And in 2019, this very good paper with 34 or 39 patients showed there were 3 subsets of prolymphocytic leukemia based on MYC and 17p abnormalities. One, what they call as low risk with no MYC activation and absence of 17p deletion. And then you had the intermediate risk with MYC activation and absence of a normal 17p. And then you had a high risk category with 17p deletion and MYC activation. And you can see the differences in outcomes in these 3 subsets. So one of them, which has neither MYC nor 17p abnormalities, almost has a survival like CLL. And then here you have it, both of MYC and 17p deletion, which is extremely poor outcome. So again, bringing to surface that this is not a distinctive disease. The multiple diseases have been put together under prolymphocytic leukemia. So in the 5th edition of the WHO classification, we made several changes. Hairy cell leukemia remained the same as what it was defined before. There are no changes. Splenic marginal zone lymphoma, bulk of it would be classified as splenic marginal zone lymphoma. But a subset of splenic marginal zone lymphoma, which has got increased numbers of large cells, and that was difficult to classify. Like in any marginal zone lymphoma, we do not have a distinctive cutoff. When do you call something as a diffuse large B-cell lymphoma? And the same thing is reflected in splenic marginal zone lymphoma, which as it progresses can have more large cells. And a subset of them would now be classified as splenic B-cell lymphoma leukemia with prominent nucleoli. Then splenic diffuse red pulp small B-cell lymphoma, leukemia. Many of them would be classified as the same disease if you have splenectomy specimen, but a subset of them with larger nuclei, where there is features of progression, would be classified as splenic B-cell lymphoma leukemia with prominent nucleoli. The earlier category of B, prolymphocytic leukemia, we had already separated out mantle cell lymphoma in the previous WHO classification, so that is distinct. In the remaining ones, the CD5 positive ones would be classified as prolymphocytic progression of CLL, and the CD5 negative ones would be classified as splenic B-cell lymphoma leukemia with prominent nucleoli. Then CLL with more than 15% prolymphocytes would be classified as prolymphocytic progression of CLL. So this finally leads us to splenic B-cell lymphoma leukemia with prominent nucleoli, basically an amalgamation of Harris leukemia variant, CD5 negative B prolymphocytic leukemia from these two from the previous WHO classification, and a subset of splenic diffuse red pulse B-cell lymphoma and a subset of splenic marginal zone lymphoma would also with larger cells and cells with prominent nucleoli would end up being called splenic B-cell lymphoma leukemia with prominent nucleoli. So just to reiterate the transition from the revised 4th edition to the 5th edition, what used to be called BPLL, if it is CD5 positive, make sure it's whether it's a mantle by look for 1114 translocation or cyclin D1 overexpression. If it is present, it is a mantle cell lymphoma, often a blastoid type. If CD5 is positive and has no evidence of CCND1 translocation, it is prolymphocytic transformation or prolymphocytic progression of CLL, SLL, which also has CLL, SLL with more than 15% prolymphocytes. If it is CD5 negative, what used to be CD5 negative BPLL would be now reclassified as splenic B-cell lymphoma leukemia with prominent nucleoli. So I want to reiterate here, the splenic B-cell lymphoma leukemia with prominent nucleoli is a placeholder. It is not a distinct entity. The distinction between 5th edition WHO classification and the revised 4th edition was, it was made to believe that the B prolymphocytic leukemia and Hepatosplenic leukemia variants were thought to be as distinct entities, whereas here we are upfront saying that this is not a distinct entity, it is a placeholder. But what is it a placeholder for? Some of these could be progression from splenic marginal zone lymphoma. As we go forward, we need to identify what are reliable criteria for diagnosis of splenic marginal zone lymphoma and take that out of the splenic B-cell lymphoma leukemia. Can 7q32 abnormalities be a defining feature of splenic marginal zone lymphoma? Similarly, the subsets of progressed or evolved splenic diffuse red pulse small B-cell lymphoma eventually needs to be taken out once we identify reliable criteria for diagnosis. Though we have placed CD5 negative PLL under the category of splenic B-cell lymphoma leukemia with prominent nucleoli, one should also think, is it possible that CD5 can be lost during the progression of CLL to a prolymphocytic when prolymphocytic progression happens in a CLL? Or there are subsets of CLL where CD5 is weak or almost negative. When they progress to can they look like CD5 negative, what used to be called CD5 negative prolymphocytic leukemia, what is now called splenic B-cell lymphoma leukemia with prominent nucleoli. There are other indolent B-cell lymphomas, as I mentioned earlier, which also need to be excluded, but there are fairly good markers to identify, like BCL2 translocation or MYD88 mutation, to identify these cases. So once we exclude all these things, probably we may be left with something more unique, a unique form of splenic B-cell lymphoma leukemia with prominent nucleolus. The question also comes, can there be a primary splenic diffuse large B-cell lymphoma? I think this needs to be addressed as well. Then, although Hepatosplenic leukemia is a very stable disease, there are rare case reports where disease progression occurs into cells which are looking more aggressive. So that's something that one has to keep in mind. So the current description in the WHO classification of splenic B-cell lymphoma leukemia with prominent nucleoli is an amalgamation of what features had been described for B prolymphocytic leukemia and Hepatosplenic leukemia variant. I'm not going to reiterate all this, but it's important to realize that it can have, like what we discussed under BPLL, it can have MYC abnormalities, immunoglobulin abnormalities. It can have trisomy 12, like feature of CLL. What is absent is BRAF mutation. That is important to recognize. And some of them can have MAP2K1 mutations, like what had been previously described in Hepatosplenic leukemia variant as well. And then, like in the splenic diffuse red pulse small B-cell lymphoma, some of these can have CCND3 mutations. So there is an amalgamation of, and again, some of them can have 7q abnormalities, deletions like one would see in splenic marginal zone lymphoma. So the definition of splenic, the essential criteria for splenic B-cell lymphoma leukemia with prominent nucleolus is morphological. In circulation, one should see these large cells with prominent nucleolus, often a single prominent nucleolus. Then they express B-cell antigens, and one should clearly exclude heritage leukemia based on immunophenotype and morphology. If one has splenectomy, it would have diffuse involvement of spleen, splenic red pulp, and atrophy of white pulp. Again, there should BRAF mutation should be absent to make this diagnosis. But if you look at the immunophenotype, I think we discussed this in quite detail. CD11C, CD103, CD123, these are defining features of heritage leukemia. There is some evidence to suggest that the ratio of CD200 to CD120 being less than 0.5 may be distinctive of splenic diffuse red pulse small B-cell lymphomas, but otherwise there is quite a bit of overlap in the immunophenotype between splenic diffuse red pulse small B-cell lymphoma, splenic marginal zone lymphoma, and splenic B-cell lymphoma leukemia with prominent nucleolus. So I just want to bring here a decision tree of how we approach these lymphomas. So if you see a B-cell lymphoma leukemia with the splenic presentation, first make sure it is not representative of a systemic B-cell lymphoma leukemia, which is presenting in the spleen. So once you exclude that, what you call as a primary splenic B-cell leukemia lymphoma, heritage leukemia is very distinctive, both by morphology, by genotype, by immunophenotype, and that can be confidently diagnosed in peripheral blood and bone marrow specimen, and you don't need a splenic specimen. Then you have a category of splenic marginal zone lymphoma and splenic diffuse red pulp B-cell lymphoma, where you can come to this these two differential diagnoses on peripheral blood and bone marrow, and maybe some immunophenotypic features may distinguish these two. Ideally, the distinction of this is done on a splenectomy specimen. Then once you exclude these two categories, if you have in peripheral blood and bone marrow in a splenic lymphoma with aggressive nuclear features, presence of medium-sized to large cells with a prominent nucleolus, that is what would be classified as splenic B-cell lymphoma leukemia with prominent nucleolus. After taking out all these entities, if you are left with any other primary splenic B-cell lymphoma, where the cells look indolent, the cells are small, but you can't fit them into heritage leukemia, splenic marginal zone lymphoma, or splenic diffuse red pulp B-cell lymphoma, you may use the family category or the umbrella category of a splenic B-cell lymphoma leukemia. But I suspect this is not going to be a significant proportion of cases. This would be very unusual to put a case into that category. I just want to draw an analogy regarding splenic B-cell lymphoma leukemia with prominent nucleolus by looking at how our concepts have evolved in diffuse large B-cell lymphoma and in double-hit lymphoma. We know diffuse large B-cell lymphoma or double-hit lymphoma could either be de novo, or it could represent transformation or evolution from a clonally related follicular lymphoma, a CLL, SLL in case of a Richter transformation, a marginal zone lymphoma, and less often lymphoplasmacytic and nodular lymphocyte predominant Hodgkin lymphoma. So today we understand that diffuse large B-cell lymphoma or a double-hit lymphoma could either be de novo or a transformed low-grade lymphoma. I suspect our current concepts of splenic B-cell lymphoma leukemia with prominent nucleolus is similar in the sense there could be a de novo, a subset of this, a minority of this could be de novo splenic B-cell lymphoma leukemia with prominent nucleolus, which we may be eventually able to define based on genotype and phenotype, and may have a different name altogether at that point in time. But a significant proportion of these represent transformation and evolution from other diseases like splenic marginal zone lymphoma, splenic diffuse red pulp small B-cell lymphoma, CLL, SLL. So from this, I'll move on to the T-cell. Oh no, before I go, I just want to share with you a couple of systemic B-cell lymphomas, which can present with splenomegaly. So here is a 36-year-old man who presented with massive splenomegaly, but also had cervical lymph nodes, and lymphocyte count was around 33,000. And here you can see lymphocytes having scanty cytoplasm, almost no cytoplasm, indented nucleus. It's a small to medium-sized cells with indented nuclei, minimal amount of cytoplasm, and these were positive for B-cell markers. FMC7 was strongly positive, CD5 was positive, 23 was negative, and FISH studies showed a CCND1 IgH translocation. And the final diagnosis in this is a peripheral blood involvement by mantle cell lymphoma. Here's another case where you can see there are small lymphocytes. Here is a 46-year-old man with a big spleen, no significant lymph nodes. White cell count was very high, so CD5 positive. CD200 was moderate to strong positive. CD23 was positive. FISH was CCND1 was negative. And you can see slight variation in cell size, some larger cells, some smaller cells as well. And here you can see some cells with smudged nuclear features. Here are smaller lymphoid cells, and then you have got some larger cells with prominent nucleolus. And these larger cells accounted for around 20%. So this is, sorry, there's a typographical error here. This is a prolymphocytic progression of CLL, SLL. Here's another case with the bone marrow is diffusely involved in a patient with splenomegaly, anemia, and lymphadenopathy. And here higher magnification shows lymphocytes, lymphoplasmacytic cells, and plasma cells. And plasma cells have multiple inclusions. And here 138 is positive in plasma cells, and CD20 is positive in lymphoid cells. And VS38C highlights more cells than CD138, indicating some of the lymphoid cells are also VS38C positive in addition to the plasma cells. CD25 is positive in the lymphoid cells, and you can see the plasma cells are lambda light chain restricted, and IgM and IgD are positive in the lymphoid cells and the plasma cells. So here, positive along with B-cell markers, there was positivity for VS38C, positivity for CD25, IgM, IgD, there was focal expression of TRAP and CD23, and there was lambda light chain restriction, and plasma cells also showed lambda light chain restriction. And mutation studies showed MYD88 mutation, and a diagnosis in this is clearly a lymphoplasmacytic lymphoma. We now move on to the T-cell categories. Here's a 50-year-old man with splenomegaly, and lymphocytes were 3.5 thousand. And here you can see these cells have got granules. They have abundant cytoplasm. The nuclear features is coarse chromatin, not clumped, but coarse chromatin. And distinctly, many of these cells have cytoplasmic granules. And bone marrow in this shows subtle excess of T cells, which were CD8 positive T cells. And clonality studies were undertaken on this. There was clonal TCR gamma gene rearrangement, and there was STAT5B mutation. So this is a case of T cell large granular lymphocytic leukemia involving blood and bone marrow. This is a case from my previous collection from the Hammersmith Hospital. You can peripheral blood morphology showed large granular lymphocytosis. And here you can see these cases which CD8 positive T cells for 4,200 cells. And these all partially express CD57. Then you can see here they're negative for CD26, CD11C, and the CD7 is almost weak to negative in these CD8 positive T cell. They're also negative for CD25 and CD28. Again, gene TCR gamma showed clonal rearrangement. Here's the bone marrow from another case, which shows very subtle infiltration by small lymphoid cells. And these cells are cytotoxic T cells, CD8 positive cytotoxic T cells with co-expression of CD57. and cytotoxic molecule perforin in this case. Another patient, 80-year-old man with relative lymphocytosis and pancytopenia, which shows, again, very subtle infiltration by small lymphoid cells, which are here CD3 positive. CD5 is lost in this case, and CD2 is maintained. So there is loss of CD5. There is, these are CD8 positive cells, which are co-expressing CD56. Unlike in the previous case, which was co-expressing CD57, here there is co-expression of CD56. Again, another case of T-LGL leukemia. CD57 co-expression is almost not there, but it's positive for cytotoxic molecules, perforin and granzyme B. Again, there was clonal TCR gamma gene rearrangement, and a diagnosis is T-cell large granular lymphocytic leukemia. So here we have again, diagnosis of T-LGL leukemia often takes multiple investigations over a period of time. Often these patients have low-level lymphocytosis, and we want to make sure that these lymphocytosis, the clonal lymphocytosis, is persistent. It goes beyond 3 months. You see them on multiple occasions to make sure that it is persistent. And ideally, you should have more than 2,000 cells. It should be a large granular lymphocyte. You have to actually calculate the proportion of abnormal T cells on flow cytometry and taking total absolute lymphocyte count into consideration. Patients have splenomegaly, they have cytopenias and symptoms related to cytopenias like bruising. They often have autoimmune diseases, most of them being rheumatoid arthritis. They often have polyclonal hypergammaglobulinemia, and they may also have positive anti-nuclear antibodies. Peripheral blood lymphocytes show minimal nuclear irregularities. They have condensed chromatin. They have abundant pale staining cytoplasm, and importantly, they show abundant azurophilic granules. And in the bone marrow, they may show interstitial, intrasinusoidal infiltrates. You may also see nodular lymphoid aggregates, and often these nodular lymphoid aggregates have abundant B cells, and often they represent a follicle. Typically, they have recurrent mutations in STAT5B or STAT3, and they may show alterations in the PIK3-ACT pathway or NF-kappa-B pathway, and mutations in TET2, TNF-EIP3, BCL11B, FLT3, and PTPN23 are noted. The most common that I often see is TET2 mutation, in addition to STAT5B or STAT3 mutation. They're mostly CD8 type, but you can also have CD4 positive type, and rarely they can be double positive as well. Cytotoxic molecules are almost always expressed in these large granular lymphocytes. Most of them are TCR alpha beta positive. Rarely they can be gamma delta positive. They often show a co-expression of, sorry, this should be CD16. There's a typographical error. They often show NK cell markers expression, CD56, 57, and CD16. CD57 is the most frequently co-expressed NK cell and antigen. They're often negative for CD5. The criteria for diagnosis is there should be increased number of cytotoxic T cells, often more than 2,000, and it should be persistent. And the population should have an aberrant, you should be able to establish an aberrant immunophenotype by like downregulation of the pan-T cell antigens like CD5 or CD7, abnormal expression of NK cell antigens like CD16, CD56 or 57, and then expression of other NK cell associated receptors, which is often seen with the KIR receptor, CD94, in more than a third of cases. And it should always establish clonality. And it's useful to establish clonality, especially over a period of time where you can show the persistence of the same clone. What would be desirable is to have a bone marrow biopsy. Not every patient undergoes a bone marrow biopsy. What is desirable is to have a bone marrow biopsy to establish increased numbers of abnormal T cells in interstitial or intrasinusoidal location in the bone marrow, and demonstration of STAT3 and STAT5B mutation in the peripheral blood or bone marrow sample. Here's another case which, as you can see, distinctive from the previous one, these cells look very aggressive. This is one of the old Hammersmith collection where patient had more than 250,000 lymphocytes. It's a highly abnormal medium to large size lymphoid cells with prominent nucleolus and a fair degree of pleomorphism. And in those days, this was called as T-cell proliferative leukemia. And here is a more recent one, about 7-8 years back. It was seen at the Hammersmith Hospital. Here's an abnormal CD4 positive T-cell population, which you can see is doubly positive. Okay, this is CD5 is weak in this population. CD3 is mostly negative, as you can see here. CD3 is surface CD3 is negative, but if one does cytoplasmic CD3, it would be positive. It is positive for CD2 and CD7. It's positive for CD8. CD4 is not shown, but I think CD4 would have been positive in this case, and shows strong expression of CD52, and it is negative for NK cell markers CD16 and CD57, and it is positive for CD26. And this is another case, again, from Hammersmith Hospital, where you can see these cells are positive. They show weaker CD2. This is the abnormal population that we are talking about, which is CD4 positive, but CD8 negative. And here, the typical morphologic features of PLL cells with cytoplasmic basophilic cytoplasm with cytoplasmic blebs. And it showed 14q11 TCR alpha delta break. Translocation inversion 14 was present. In addition, there was gain of 8q24 and loss of 11q23. So often the characteristic abnormality is translocation involving TCL1 and juxtaposing of TCL1 to TCR alpha delta. Very rarely you may see TCL1 being juxtaposed to TCR beta. Here is another case which was seen at the Fred Hutchinson Cancer Center, where we see these abnormal lymphoid cells. And here's actually a lymph node from this patient who had a lymph node biopsy subsequently. And here you can see it is diffusely infiltrated by these abnormal cells. And TCL1, which is the protein that gets expressed as a result of TCL1A translocation, is upregulated in TPLL. And here you can see strong expression of TCL1 in these lymphoid cells. And one of the characteristic features, which is seen in around 30 to 40% cases, is double positivity to CD4 and CD8. The unusual feature of this case was, though there was TCL1 translocation, TCR alpha delta was not rearranged. And here the translocation partner for TCL1 was actually TCR beta. So T-cell proliferative leukemia often present with high lymphocytosis. They often have thrombocytopenia, anemia, hepatosplenomegaly with minimal or no lymphadenopathy. And often you get skin involvement, particularly at the time of relapse, and effusions in around 15% cases. There's marked lymphocytosis. Typically, they're small to medium in size. They have non-granular basophilic cytoplasm, round oval or markedly irregular nuclei with visible nucleoli. There is basophilic cytoplasm with protrusions of blebs. A small cell variant and pleomorphic variant have also been described. And bone marrow biopsy typically shows diffuse infiltrates. As I said earlier, the classic genetic abnormalities in version 14, which are translocation 14-14, resulting in juxtaposition of TCL1A to TCR alpha delta, and rarely to TCR beta, as I showed you. A subset of cases have been described, 5% cases have been described to show X14 translocation, where MTCP1 is translocated to TCR alpha delta. These cases have immunophenotypic phenotypic features and morphology very similar to TPLL, and they would be classified as TPLL. According to WHO classification, either of these two is essential. But there are other societies which have suggested that there can be you can diagnose TPLL even in the absence of TCL1, TCL1A or MTCP1 translocation based on the morphology and immunophenotype. And I will discuss with you what could be the problems of such an approach. Immunophenotype, typically the CD3 is weak. There can be some CD7 is usually stronger in TPLL than normal T cells. The typical phenotype is CD4 positive, CD8 negative. Some of them can be dual positive for CD4 and CD8. Very rarely they are CD8 positive and CD4 negative. 52 is strongly expressed. And TCL1A is a protein is positive, which you can demonstrate by immunohistochemistry. And cases which look very atypical, one should exclude T lymphoblastic lymphoma leukemia by absence of CD1A and TDT. So WHO classification requires one, presence of lymphocytosis, documentation of TCL1A or MTCP1 translocation, or using TCL1A protein expression as a surrogate for TCL1A translocation, and evidence of T-cell monoclonality. In the absence of these, some of the societies have suggested that in the absence of one of these typical translocations, one could use other abnormalities which are frequently seen in TPLL, like abnormalities of chromosome 11, which results in deletion of or mutation of ATM, abnormalities of chromosome 8, abnormalities of other chromosomes like 5, 12, 13, or 22, or simply presence of a complex karyotype or patient presenting with splenomegaly and effusions. I want to share with you one case where this was a patient presented at the Fred Hutchinson Cancer Center about 10 years back, presented with lymphocytosis with atypical lymphocytes. And as you can see on flow here, this was dual positive for CD4 and CD8. And then CD7 was strong, and CD52, which is not shown here, was also positive, and the T-cell population. And some of them were very atypical. This patient lacked TCL1A translocation, but had MTCP1 translocation and was called TPLL, which it fits all the current criteria for TPLL. And patient was treated initially with anti-CD52, followed by stem cell transplantation. Then 8 years later, patient presents with inguinal lymph node, no lymphocytosis, and peripheral blood flow completely clear. And the lymph node here shows monomorphic proliferation of medium to large, medium-sized cells, which are CD3 positive, strongly GATA3 positive. CD4 is completely lost now, and CD8 strongly positive with cytotoxic molecule TIA1 being positive. We did, again, we repeated FISH for TCL1, which was negative, and we did clonality studies, which is exactly the same clone as what it was before. So this brings to question cases which are TCL1 translocation negative. In this case, it was even MTCP1 positive, but other cases which MTCP, if you look at literature which were MTCP1 and TCL1A negative, they have been classified as TPLL based on complex karyotype or based on ATM deletion or mutation. Their biology may be different. Many of them did not have significant splenomegaly. Even this patient did not have a very large spleen. There was some splenomegaly, but it was not very large. So do these actually represent TPLL, or can these be a form of peripheral T-cell lymphoma? We know a subset of peripheral T-cell lymphoma, NOS, has this kind of uniform nuclear cytological features along with strong expression of GATA3. So can some of the peripheral T-cell lymphomas present in a leukemic phase and can be mistaken for TPLL? That's something worth considering. Then this is another entity, which again, quite a rare entity. I've seen very few cases of. Here is a bone marrow with intrasinusoidal infiltrate of these abnormal cells. And these cells, abnormal cells within the sinusoids, and to an extent which is also in the interstitium, here you can see they express CD3 and CD2, and they also express CD56, and they're negative for CD5. This is a very good example of hepatosplenic T-cell lymphoma. In this case was gamma delta positive. And you can see it's double negative for CD4 and CD8. So hepatosplenic T-cell lymphoma is quite an aggressive mature T-cell lymphoma, where there are cytotoxic T-cells. It can either be alpha beta or gamma delta, though gamma delta is a far more frequent subset. And this involves spleen, liver, and bone marrow. Patient often present with marked hepatomegaly, splenomegaly, and they often have B symptoms and can have skin involvement, particularly at the time of relapse. Typically, these are younger patients and other lymphomas that we discussed. They present with neutropenia, and the neoplastic lymphoid cells are small to intermediate in size with irregular nuclear contours, dense chromatin, and have a small nucleolus. They have pale granular cytoplasm. They have blastoid or pleomorphic appearing nucleus. And bone marrow typically shows intersinusoidal pattern of infiltration. Often it happens in around 20% of these cases, you have a background of immune dysregulation. It could be in a post-transplant setting. It could be patients on immunosuppressive therapy, or even autoimmune diseases. So immune dysregulation is seen around 20% cases. As a characteristic abnormality that you see here is isochromosome 7q, and then you can have mutations in the JAK-STAT pathway and chromatin epigenetic modification pathway genes. Immunophenotype is quite characteristic here. It's got downregulation of CD5. It's typically negative for CD4 and CD8. CD8 definitely being negative and EBER being negative. And 3/4 of them are gamma delta T cell type. 20% of them are alpha beta, and 5% can be null phenotype. And they typically express CD56 or CD16. So the criteria for diagnosis is the characteristic extranodal and sinusoidal involvement of liver, spleen, and bone marrow, small to intermediate size lymphoma cells without any intracytoplasmic granules demonstrated cytotoxically. I think there is a mistake there, I think. Yeah. Then desirable criteria is absence of CD4 and CD8 and downregulation of CD5 and CD56 being frequently positive. Isochromosome 7q is a characteristic abnormality, and many of them also have trisomy 8. Here is a case of hepatosplenic T-cell lymphoma. Two cases here. One is of gamma delta type, and the other one is alpha beta type. And here you can, this one was the gamma delta one was only partially CD56 positive, whereas the alpha beta type was strongly CD56 positive. And the here CD5 is negative in both of them, and CD4 was negative again in both of them, and the alpha beta type was partially expressing CD8. Here is a liver biopsy. This is the only one which I'm showing outside the bone marrow here. We're showing subtle intrasinusoidal infiltrates of these abnormal gamma delta T cells, as in this case, which was also expressing CD56. So I would want to end with what can be mistaken in the T cell areas for a primary splenic T cell lymphoma. Here was a patient, a 60-year-old man, presented with pancytopenia, and there was a question of hemophagocytic lymphohistiocytosis. There was hemoglobin was low, white cells were low, and platelets were also low. So there was pancytopenia, and bone marrow was hypercellular. There was trilineage hematopoiesis, no dysplasia, and no obvious lymphomatous involvement. And the aspirate did not show distinct hemophagocytosis. Flow showed increased numbers of gamma delta T cells, and these T cells were larger. As you can see here in the red population, the cells that had a higher site scatter, and these are gamma delta T cells, which was CD56 positive, and CD CD2 positive. And here in the bone marrow, again, the infiltration by these cells was very subtle. And it's not very obvious in the H&E, but when you look at immunostains, you can see there is a subtle infiltrate of CD3 positive cells. And these cells were also EBER positive. And so it's very important to do EBER stain in many of these T-cell infiltrates in the bone marrow. And here with a double stain, we showed that the EBER positive cells were also CD3 positive. And we knew by flow this was gamma delta T cells, and we knew CD56 expression. So we further went on to show that these EBER positive cells were also weakly positive for CD56. And so the overall, the phenotype of this was CD3 positive, 56 and 57 in a subset positive, granzyme B positive in a subset, 30 positive in a subset, EBER positive, double negative for CD4 and CD8, negative for TCR beta, but positive for CDR gamma delta on flow. And there was monoclonal rearrangement of gamma delta of the TCR gamma gene. Then we looked at EBV viral copy numbers, and this patient for over a long period of time showed increasing and EBV, and then in between it had come down on its own to rise again a little later, and so had continuous EBV viremia. So this was diagnosed as a systemic chronic active EBV disease of T cell type, and in this type with gamma delta. And subsequent, a later bone marrow biopsy in this patient showed features of HLH, which was not obvious in the initial presentation. And then he had a liver biopsy, which also showed subtle involvement. Finally, patient ended up getting chemotherapy and an allogeneic stem cell transplantation. So systemic chronic active EBV disease shows systemic proliferation of, it could be polyclonal, oligoclonal, or as in the case that I showed you, monoclonal EBV positive T cells or NK cells. And the symptoms should persist for at least 3 months. And patients usually have a fever, lymphadenopathy, hepatosplenomegaly, anemia, thrombocytopenia, some of them diarrhea. So varied symptoms can be present in these patients. And so suspicion of this entity can be difficult clinically. So if they often have hemophagocytic lymphohistiocytosis, patient may present with multi-organ failure. And one of the features that you can't see is the subtle sinusoidal infiltrate of lymphoid cells in bone marrow, liver, and spleen, and in lymph nodes. And these lymphoid cells may have minimal or no atypia. And bone marrow biopsy can show intersinusoidal pattern of lymphoid infiltration. Often the EBV shows type 2 latency, and EBV somehow finds mechanisms of not being detected on the positive cells. And then often these patients have somatic mutations in DDX3X. And then also abnormalities, intragenic deletions in the EBV genome. And the T cell, the phenotype often shows T cell markers, cytotoxic molecules. It can be T cell type or NK cell type, often and the NK cell ones also show cytotoxic molecule expression. CD4 is more frequent than CD8. Those cytotoxic molecules are expressed. TCR alpha beta is more frequent than gamma delta, and a constant feature is positivity for EBER. So essential criteria for this is infectious mononucleosis-like symptoms persisting for more than 3 months, increased EBV DNA in peripheral blood or EBER positive cells in the affected organs with evidence of EBV infection in the T cells or NK cells. Not always it is possible. Double stains are not available in all places. And exclusion of immune deficiency. If it is immune deficiency positive, then by classification, it would, you can, even in an immune deficiency setting, you can get, but in the WHO classification, if you have immune deficiency, it is categorized as immune dysregulation associated lymphoproliferative disorder. But under the immune dysregulation lymphoproliferative disorder, you would still call it as a disease very similar to systemic chronic active EBV disease. So I've just put together a table which helps to distinguish between different categories. The 4 categories that we have discussed here: TLGL, TPLL, hepatosplenic T-cell lymphoma, and systemic chronic active EBV disease. So you can ask several of these questions, and this should help you to come to a diagnosis. Is cytoplasmic granules present, typically seen in TLGL? Can be seen in systemic chronic active EBV? Is it typically CD4 positive disease that is characteristic of TPLL? Again, characteristic of systemic chronic active EBV disease. Typically CD8 positive disease that is typical of TLGL. If you have a double positive disease, again, quite typical of TPLL. Double negative disease that is typical of hepatosplenic T-cell lymphoma. Alpha beta more frequent, that is TLGL and TPLL. TPLL is always alpha beta. TLGL is most frequently alpha beta, rarely can be gamma delta. Systemic chronic active EBV is also more often alpha beta positive and rarely gamma delta. If it is predominantly gamma delta disease, more likely to be hepatosplenic T-cell lymphoma. Cytotoxic molecules can be positive in LGL, hepatosplenic T-cell lymphoma, and in systemic chronic active EBV disease. EBV is negative in all other T-cell lymphomas that we have discussed, apart from systemic chronic active EBV disease. TCL1A or MTCP1 rearrangement is characteristic of TPLL and not present in other diseases. Isochromosome 7q, characteristic of hepatosplenic T-cell lymphoma, not present in other diseases. Somatic mutation in DDX3X, characteristic of systemic chronic active EBV disease, not present in other ones. Other mutations like STAT3, STAT5B, these are not, though they are frequent, they are not diagnostic of a particular disease. I think I would end there. Be happy to take questions. Thank you.
Thank you, Dr. Naresh. Fantastic. Enjoyed listening to you. So much has happened in this field. So we will use raise hand sign for our colleagues to ask question. Can I ask you first question, which a lot of people have put in the chat box, and which is my query also. When you have a middle-aged or elderly person with a large spleen, and there is no clue from the blood, bone marrow aspirate, and bone marrow biopsy, including flow and IHC, how often you see such cases, and what do you do for such cases? And the questions that have been put up in the chat box is due to FNAC, splenic biopsy, stomectomy, and short questions have been put.
Yeah, but the important thing is to look at the imaging findings of spleen, whether it is there are focal lesions in spleen or there are no focal lesions in spleen. I think if there are focal lesions in spleen, it becomes much easier. I would definitely suggest to go for a needle core biopsy, because that would be spleen involvement by other diseases, maybe infective, maybe neoplastic. So, and also I have seen patients with focal lesions in spleens. Splenic core biopsy is very safe to do and very much easier to interpret. But if it's a diffuse involvement of spleen, diffuse enlargement of spleen, I think the differential diagnosis becomes extremely wide, from hypersplenism to splenic other neoplastic disorders. So there, I think one depends on how acute the condition is, whether you want to wait, how deeply you will go into assessing the peripheral blood lymphocytes, whether you would first do clonality on peripheral blood lymphocytes, do mutation studies on peripheral blood lymphocytes, and probably splenic biopsy. People would reserve it to the end.
Thank you. When we talked about the clonality study, their question, the T-cell clonality based on flow versus PCR to distinguish reactive versus a malignant process.
Yeah, I think more recently we do TCR C-beta 1 on flow, and also we do V-beta analysis on flow to identify restricted populations. Again, people have to understand, like kappa lambda, similarly C-beta analysis is an analysis for restriction. It's a surrogate for clonality. it is not clonality itself. So yeah, it is useful to do because you can then look at specific populations. You can look at populations, say, which is downregulated CD, which is negative for CD5 or downregulated CD7. So you can look at specific subsets of T cells. You can do analysis and you can look at the restriction. It is quite useful. But again, I mean, then you need to come to a diagnosis of a lymphoma, you need other things. It's a useful indicator of a clonal disease.
Well, the questions related to the splenic lymphomas, especially hairy cell leukemia, how often it can happen without splenomegaly?
Yeah, spleen, yeah, in early phases of the disease, spleen may not be very large. And a minimal splenomegaly may be there. So your index of suspicion has to be high when you see a patient with cytopenia, monocytopenia. I think a patient with cytopenia who goes for a bone marrow investigation, definitely one should do at least a CD20 and CD3 to look at the number of B cells. And also, in a general context, also do CD34 because it also do a PNH analysis. A patient with cytopenia doesn't have a big spleen. Make sure it's aplastic anemia, PNH, hypoplastic, MDS and AML, hypoplastic, hairy cell leukemia. All these should be in your differential diagnosis.
Another one is, how do you differentiate SMZL transforming to DLBCL from SBLPN?
Yeah, I mean, as I showed you one case where that was precisely the differential diagnosis. Even in a lymph node or in an extranodal site, when you have a large amount of tissue, the definition of a diffuse large B-cell lymphoma is sheets of large cells. And in a peripheral blood, you can't see sheets of large cells. In a bone marrow, if you see sheets of large cells, clearly large abnormal cells in sheets, yes, that's a DLBCL. But if you do short of that, when you have medium-sized cells, slightly larger looking, where the nucleolus is prominent, that is a problem. And I think the distinction, that's where I think you have to look at 7q abnormalities, you have to look at the mutation pattern, you see how long the patient has had lymphocytosis, is also whether there are small lymphocytes in the background. All these parameters need to be taken into account. And like in the DLBCL, you have a DLBCL with a follicular, in the same lymph node, you may have DLBCL and a follicular lymphoma. So we have to understand that there can be a splenic marginal zone lymphoma, which may show features of progression like splenic B-cell lymphoma leukemia with prominent nucleoli. But in a rare case, you may see both element diffuse large B-cell and splenic marginal zone lymphoma in the spleen in the same bone marrow biopsy. Of course, in all these things, if you get splenectomy, it's not a difficult diagnosis. You can distinguish between what is progression of splenic marginal zone lymphoma, which will look like splenic B-cell lymphoma leukemia with prominent nucleolus, from what would be a full-blown transformation to diffuse large B-cell lymphoma.
We have two questions from the faculty present here, Dr. Akshay and then Dr. Vidisha. Akshay, right.
Thank you, sir, for the wonderful presentation. Sir, I have two questions. So first, we are having a 44-year-old male. He's having complaint of on and off fever since 2 months. He was a case of anemia under evaluation and has history of blood transfusion. On examination, he's having moderate splenomegaly and no palpable lymphadenopathy. WBC count is around 3,500. Hemoglobin is around 7 and platelets were around 1 lakh. Peripheral blood is showing few atypical cells. Bone marrow aspirate is showing 92% atypical lymphoid cells, which are large in size, having high NC ratio. And on flow cytometry, these cells are showing moderate to bright CD45 expression. CD7 expression is heterogeneous. Surface CD3 expression is moderate to bright. These cells are also positive for CD2, which is showing moderate expression, and are negative for both CD4 and CD8. These cells are positive for TCR gamma delta, negative for alpha beta, and negative for immaturity markers like 30 and TDT. Sir, cytogenetically, to see for chromosome 7 and 8 abnormality was advised, but both are coming negative. And bone marrow biopsy is not showing an intrasinusoidal pattern, but is instead showing a diffuse infiltration. So what should be the differential diagnosis in this case?
The most likely what you're seeing is and the patient also has hepatomegaly.
No, hepatomegaly is not there, so only moderate splenomegaly without palpable lymphadenopathy. But patient is not sick.
I see. But from the morphology, what you described, it looks like a diffuse involvement by hepatosplenic T-cell lymphoma.
Right.
And you say alpha beta is negative, but gamma delta was tested or not
Gamma
tested? Gamma tested. And a CD, okay. You don't have isochromosome 7q, but otherwise you have all other features. The only thing is the patient is not acutely ill. That's the
Yes, sir.
only unusual feature with this case. I think patients with hepatosplenic T-cell lymphoma, eventually they become sick. And I'm quite surprised with such a heavy bone marrow involvement. The patient is, how old is the patient, did you say?
44-year-old male.
40. Yeah, most likely what you're describing is a hepatosplenic T-cell lymphoma.
So should we give any other differential also?
No, you know it's a gamma delta T-cell lymphoma. You have patient has got splenomegaly. I think what would be your different? Can it be an LGL? That's the question, right? You want
The
to, well, how do
morphology
you
is
exclude a LGL with gamma delta type? That may be one of your differential diagnoses. So, apart from looking at cytogenetics, also probably looking at his mutation pattern would be useful. But I think cytogenetics would be the most useful thing here.
okay, sir.
The only other differential would be a gamma delta type which is rare, of LGL.
So could a TLL be considered in this case? But the majority markers are coming negative. A gamma delta expressing TLL.
Yeah, I don't know, people, TDT and negative, CD1A negative, TALL, it depends on how confident, how is your flow, in the sense, do you often get TDT expression in your outright TALs very weak, or do you get very good TDT in the rest of, in flow? And also on morphology, if your immunohistochemistry often gives you very good TDT, I find TDT extremely reliable. I can barely remember one or two cases where I have called something as TDT negative TAL.
Okay.
Okay,
Okay.
it is very unusual. I would, that would not be anywhere. It'd be very low in my differential diagnosis. And you say patient is also doing well.
Okay, sir. So two differential, basically hepatosplenic gamma delta T-cell lymphoma and gamma delta variant of TLGL.
TLG, yeah.
Okay. Okay. Thank you, sir. So I have one more case. It's a 56-year-old male. He was clinically suspicious of leukemia or tumor lysis syndrome, presenting with hematuria, mild to moderate splenomegaly, and no palpable lymphadenopathy. WBC count was around 10,000. He was having 25,000 platelet count and anemia. On flow cytometry, almost all the cells are abnormal. They are showing moderate to bright CD45 expression. Co-expression of 19 and 10 was seen, and these cells are also co-expressing CD38. But CD20 is present only in a subset of these cells, and these cells are negative for CD34, TDT, IgM, and kappa lambda. And when biopsy was done, it was showing diffuse positivity, diffuse infiltration with large atypical cells having vesicular nuclei. And biopsy IHC was also showing positivity for CD19 and CD10, but to our surprise, a strong positivity for CD20 was seen.
Mm-hmm.
So based on this, what should we prefer a pre-BLL, because on flow cytometry the 20 was seen in only a subset, or
And what about TDT?
TDT negative, 34
TDT
TDT both.
negative. And did you do FISH for MIC?
No, sir, not
BCL2?
done. But IgM was negative. BCL2 on biopsy is coming positive, sir.
BCL2, okay. I mean, I would definitely do cytogenetics in this case. From what you're describing, it could even be, it could be a MYC positive disease. It could be a double hit. If it is BCL2, if it is coming strongly, it goes against a Burkitt lymphoma. But and the patient is quite symptomatic, definitely should exclude a double hit lymphoma case like this. With
And so
CD10
what?
positive.
Yes, sir.
Go ahead.
Okay. So what could be the cause of this discrepancy that in flow we are seeing only a subset of CD20 positive cells, indicating that these are more immature cells, and on IHC we are getting strong positivity, and in
No,
flow actually using cocktail of antibody. So the other case which came the same day, it's showing good positivity for CD20.
yeah, it's one. I mean, obvious thing is whether it is the CD20 is not expressed on the surface and more in cytoplasm. That's one thing. The antibodies are not exactly the same. I think what you use in flow and in what you use in, whether some of them there is
Right.
different isoforms or mutations in CD20, shedding of CD20. There can be various reasons. And CD20, the one you use in immunohistochemistry, is a very robust antibody. It even, I mean, it always comes stronger. But I think in many mature B-cell lymphomas, even in immunohistochemistry, you can have a weaker CD20. You can see in many large B-cell lymphomas, variability of CD20 you see. But so just because CD20 is weaker on a subset of cells, I don't think that's a good way to diagnose a lymphoblastic lymphoma.
Right. In absence of immaturity markers.
Yeah.
Okay. Okay. Thank you, sir.
Thank you, Vidisha.
Thank you, sir. That lecture was really extensive, and especially with the new entities in WHO, it's nice to know in which category it falls. So there's a very practical question. So we have many cases in which we have interstitial nodules of lymphoid follicles coming in. They are sometimes many in number, 5 to 6. When we do a 3 and 20, you'll see an admixture. Sometimes 20 is brighter than 3, but then sometimes there's an admixture, and the patient might have splenomegaly in this case. Is there any clear-cut definition? How do we differentiate between a benign aggregate in a bone marrow versus a malignant aggregate in a bone marrow, other than the paratrabecular location, which most of the text describes? Anything else, sir?
No, if what the nodules look reactive in the sense you've got a mixture of CD20 and CD3 positive cells, also look at what's happening in the interstitium outside the follicles. And obviously, you investigate the follicles and see whether you exclude, if it is intertrabecular follicles, unlikely for it to be follicular lymphoma, but exclude it. Look at CD10, BCL6, BCL2. But more important than that is to look at the interstitial component, because you can have like a splenic marginal zone lymphoma, you can have reactive follicles, and then you have interstitial element, which is splenic marginal zone lymphoma, or also even things like LGL. You can have prominent B-cell nodules. You can have follicles in LGL leukemia. So look at the interstitial component. Look at the phenotypic features of the interstitial component. Look for intrasinusoidal, if there are intrasinusoidal infiltrates. In those with benign lymphoid aggregates, these aggregates are very well defined, often CD3 predominant, very well defined, without any interstitial infiltrate. So,
So because we are asking, a year back, we had a case of 49-year-old female, no lymphadenopathy, a moderate splenomegaly. Aspirate had polyclonal lymphocytes with hematogones, while the biopsy showed us these 4 to 5 lymphoid aggregates, occasional one being paratrabecular. And on IHC, the only marker which we got was 3 and 20. Like I said, there was an admixture in the periphery with more of 3 in the periphery and more of 20 in the center. But the rest of the markers were all negative. So we were only able to give something like a suspicion of involvement of the bone marrow by a lymphoma. So they had to go ahead with a splenectomy. So, there's always a question when we are asked that, can a splenectomy be avoided? Can you give us a more definite diagnosis, especially when the cytogenetics and FISH of this patient was negative? There was no pickup for any,
and what did the spleen show?
It showed a splenic marginal zone for us, sir. It was a clear
Then
cut.
I would suggest you go back to the bone marrow and look for infiltrates outside those nodules.
Okay.
Often the pathognomonic features are seen as subtle infiltrates, like I showed you 2 or 3 bone marrows where you see intrasinusoidal infiltrates on CD20.
Okay.
Yeah.
Thank you. Thank you. Thank you so much, sir.
Thank you. Gopinath.
Good evening, sir. Thanks for the lecture with lot of clarities. Sir, for Harrison leukemia, to send a BRAF 600 PCR, peripheral blood or bone marrow sample, which is the best? And if the bone marrow sample shows, apart from BRAF V600E, it's V640E, does it make any difference?
That's yeah. I think the sample, which one to choose, it depends on how much peripheral blood is involved, because most places have a cutoff of 3% VAF to call the mutation. Supposing you have only 1 or 2% lymphocytes, which are hairy cells, then I think peripheral blood becomes a problem. Because even if they do see a mutation and the VAF is very low, the lab is not going to call it positive. So in those cases, it is better to send bone marrow. In some places, I mean, people do enrichment of B cells, and then that's more difficult and more time consuming. Maybe easier would be to send a bone marrow. The question of other mutations, yes, if you have everything else that fits for hepatocellular leukemia and you have a different mutation, I mean, in most cases it is B600E. I mean, very rarely I've seen other BRAF mutations, and again, I think data needs to build up on all these things, but that doesn't exclude. Otherwise, everything else looks for like a hepatocellular leukemia, but you have a different mutation. I would make a note of it, but that again, why it is not characteristic of hepatocellular leukemia, because you can get other BRAF mutations. I've seen it in diffuse large B-cell lymphomas and other things where you can get other BRAF mutations. So it is not diagnostic, but I think then go back to morphology and immunophenotype. Because we do say only 95% we say have BRAF V600E mutation, but you have still 5% cases which do not have. So
This case had a characteristic morphology and IHC suggestive of Harrison leukemia, sir. But only thing, the mutation was just V640E. In such cases, we have a treatment implication of using vemurafenib, particularly which is approved for V600P. So whether V640E behaves as the same as V600E, because I came across 3 types of RAS pathway mutations in Harrison leukemia. So only for that treatment point, whether it behaves the same way as V600E is what my doctors.
What happened? Did you treat this patient with the BRAF inhibitor?
Yeah, I treated him with the BRAF inhibitor only, sir. But he had a very, very delayed response. Still, his counts haven't recovered actually. Because he had a fungal infection at baseline.
Yeah, these are interesting ones. I think if we collect a good cohort of cases, they are worth learning from.
Thank you, sir.
I'm sure all these, I mean, inhibitors, what specificity they have for which mutation. I'm sure many of them are specific, but they may have some cross-reactivity. You may, as in your case, you got a response, but the response was not as good as other hepatocellular leukemias.
Thank you.
Yeah,
Thank you. Thanks.
Yeah, go ahead, Gopinath.
That was, this case had a slightly delayed improvement of counts, and he was having progressive rise in liver enzymes after vemurafenib as well. So that's why I was doubtful whether, because I came across there were type 2 and type 3 RAS pathways where they can actually have a progression with BRAF inhibitor. So the subcellular pathway is same as typical V600E or V640E was one of the doubts I had during treating this patient, but still he is yet to improve his counts. So I also don't know how is he going to respond. So maybe when he responds back, then I think I can share across the information.
Yeah, sure. I would like to know. But his peripheral, his bone marrow is clear?
Yeah, his bone marrow, that is immunomorphology is characteristic. The morphology is also showing
No,
hairy
after
cells.
treatment, has he cleared his bone marrow?
It has just been 21 days, sir. 21 days
Okay.
of vemurafenib.
Okay.
Gopinathan, can I ask you one question? What is your first line of treatment for HCL?
Cladribine.
And the reason for not giving it to your patient?
Sir, actually, he had an active fungal infection.
Okay, all right. Thank you. Ramesh, your question.
So thank you for the very great lecture. I have a question. We had a patient who had typical B symptoms and was having a splenomegaly, but with the borderline cytopenia was there, but marrow did not show any involvement by lymphoma, and a patient was not willing for splenectomy. Peripheral smear did not show any atypical cells. So should we do a flow cytometry in this patient? There was suspicion of only one cell in the peripheral smear. Will flow help in this patient if there is some clonal lymphoid population which is picked up? And should we take it as significant?
Yeah, I think flow is incredibly useful in, particularly in peripheral blood and bone marrow diseases, and more so in peripheral blood when I mean, when you say bone marrow was normal, again, it depends on how intensely it was worked up. I mean, many cases that I showed you, if you just looked at the H&E slide, abnormalities would not have been so forthcoming. So, and peripheral blood in a patient with splenomegaly, peripheral blood, I think definitely flow is indicated. At a minimum, to start with either, depending on the kind of tubes that you use, either an LST or a separate B-cell tube and a T-cell tube to evaluate is very important. Because the abnormalities can be only in a subset of the lymphocytes, and the cells may not obviously look abnormal.
Okay, sir. Thank you.
Yeah.
Thank you, Ramesh. Just last two questions from the chat box. One is a question: have you come across splenic lymphomas, primary splenic lymphomas in pediatric age group?
I mean, I would hesitate to say no, but because in the last few years, my practice has been predominantly in adult oncology. So maybe I'm not the right person to answer the question.
And the second question is, in systemic chronic EBV, have you come across a patient with severe neutropenia?
Yeah, I mean, I've seen a good number of cases, and patients present with cytopenias, and cytopenias driven by ongoing HLH. And often that's the presenting symptom. I mean, they come with a very wide differential diagnosis. People ask me to look for granulomas, look for, and they wouldn't have done an EBV because it can be unsuspected. And when you have a chronically ill patient with cytopenia, always remember to exclude EBV positive disease.
One more last question. In a resource limited setting, what is your stepwise IHC approach to proceed further in CD20 positive lymphoproliferative disorders?
Okay, that's a very loaded question, I should say. Yeah, stepwise. I mean, there is always this argument about going through stepwise, doing the whole battery in one go so that you don't miss. Yeah, if I were to be in a resource crunch place, once I do instead of doing CD3, I would probably do CD20 and CD5. So I would reduce one antibody there, because that gives me more, I mean, lineage which way to go. And once if it is a primary bone marrow disease, I would probably, if it is CD20 positive disease, I would do a CD10, a cyclin D1, a LEF1, because I would already know whether it is CD5 positive or negative. I think that's where I would start. But along with that, I would, if I'm looking at a case which has got a big spleen, I'd probably tried to, at least in the place where I have worked, I have tried to do a CD123, but maybe that may be more difficult if there are resource crunches. But doing a CD5 or cyclin D1, because you want to first exclude a systemic lymphoma. But once you exclude a systemic lymphoma involving marrow, then your differential diagnosis is much narrower. And I think you can, based on what I have said, then you have to have specific hepatocellular leukemia markers. You got to have. So the important thing is to exclude other diseases by doing, and the most important thing to exclude is a mantle cell lymphoma, because the behavior is quite different.
Thank you, Dr. Naresh. I think there are questions, but we'll stop here. This has been a long day for you. Question answers have been pouring in, but thank you so much for being with us.
Thank you
Very much for obliging us all the time by accepting to do webinars.
Yeah.
And when you are in December over here, you may be on vacation, but if you can spare some time, we'd like to have a connection with you. Thank you so much. And in
Thanks
touch.
a lot.
Thank
Yeah,
you.
yeah. Have a nice day. Have a nice weekend. Bye.
Thank you, sir.
They are not there. So I will give the vote of thanks. Thanks to everybody who has joined, and thanks to everybody who has listened to us through the web. Bye-bye. Good night to all those in India.